The knot is tied and the free end is cut short, typically right on the knot. The needle is reloaded backhand, brought underneath the knot and back up through the dermis at the very apex of the wound. Once this is drawn through, the knot rotates under and is buried. Reload the needle, and now begin taking bites at the apex. Unlike a simple suture, however, these bites are taken parallel to the skin rather than perpendicular, and are kept entirely within the dermis. Draw the suture through. The next bite should come across and just slightly back from the exit point of your last bite. Again, take a bite in the dermis that's parallel to the skin. Draw the suture through, and then come across and approximately 1/3 of the way back from the previous bite. Stay in the dermis and stay parallel to the skin. Come across and 1/3 back to take your next bite. Note that the forceps are used to stabilize the skin and to evert it slightly. It's best to hold the skin somewhat away from the needle to give yourself room to work. Continue taking bites all the way along the tissue. Coming across and slightly back, staying parallel to the skin, and staying in the dermis. At the end of the incision, come up to the apex, take another bite directly across, and leave a loop to tie to. Perform your instrument tie. And then cut your suture loop, leaving your needle attached. This is cut on the knot. Reload your needle and bring the needle behind your knot, sinking it between the two layers of the tissue, trying not to grab either side. Again, sink between the tissue, come underneath your knot, and up through the skin away from the incision. When this is drawn through, it rotates the knot underneath and buries it. The suture is then cut. And the tail disappears. In order to line up the wound appropriately, each bite should be taken by coming directly across the wound and back approximately 1/3 of the distance to the last bite. By advancing forward, unsightly gaps are created in the wound. As is seen here. Another common error is to move out of the parallel plane. By coming off of parallel, it creates a buttonhole effect, as shown here. Another common error is to come out of plane into the underlying fat. This can create a lumpy incision. To perform a purse string closure, start with the needle in the backhand position. Start close to yourself. Take 1 or 2 backhanded bites. These should be nice and even. Until you can switch back to a forehand bite. To come around behind the defect. Again, it is important here to take nice, even bites. By starting towards yourself and working your way away from yourself with the initial backhanded bites, it allows your tails to be close to you at the completion of the purse string and therefore allows you to tie the knot in front of the defect. Draw both ends of the suture together, trying to dunk the defect underneath the purse string, if necessary using forceps to hold it in place as the knot is secured. A common error when performing a purse string suture is to start sewing towards yourself. Although this is tempting, in fact, it makes the purse string closure much more difficult, because after the first bite or two, it forces you to sew backhanded for a much longer segment of the purse string, all the way up the left-hand side and across the back. By setting yourself up with the first stitch backhand It avoids this awkwardness. Another common error is to forget to draw the suture through the purse string as you go. This ends up leaving a very short amount of suture left. Making it difficult to place additional sutures as you come around the purse string, and eventually forces you to drag the suture all the way through the tissue, potentially stressing the tissue. It's much better to bring the suture through with you with each bite. Another common error is to come too close to the defect. By doing this, it prevents the defect from being buried. Another error is to bring the suture too far away. It's best to take nice even sutures, allowing for a good closure of the defect. To perform a figure 8 suture ligature, first take a bite of the tissue, draw the suture through the tissue, and take a second bite. It is often helpful to use pop-off sutures to perform a figure 8. This limits the amount of suture that has to be drawn through the tissue. Secure your knot. The needle is brought through the tissue. A short segment of suture is brought through, and a second bite is taken. Protect the needle. And then pop it off. Secure your knot. For a tie on a passer, the suture should be brought around the clamp and brought down in a tip-to-tip fashion. This allows the suture to be hooked underneath the clamp. The knot is then brought down with a forefinger, and the throw is pushed just past the clamp. Communication with the assistant is essential. The assistant should not remove the clamp until you tell him or her to do so. Additional throws are then brought down and again pushed just past the knot. Scissors are then brought down in the hole to cut the tails. The most important part of tie on a passer is to bring your two clamps tip to tip. This must be done regardless of whether the clamp on the vessel is pointed to the left or to the right. Again, push the knot down on the tip side of the clamp and communicate with your assistant. The passer can be brought around the clamp on the vessel as an alternative to bringing the suture around. Depending on the orientation of the clamp and on the passer, it is always important to bring them around tip to tip. In this example, the clamp is pointing to the left. The suture was brought around behind, and the passer was brought down tip to tip. Again, bring the knot down to the tip and communicate with your assistant. This is an example of a common